Hello, everyone. Welcome to our platform topic tonight. We're talking about weight loss. I am Dr. Celia Egan. I'm an internist and the director of obesity medicine and metabolic health at True Women's Health, which partners with all these amazing practices of Together's Women's Health. And tonight we want to provide a space for all the women out there to ask all the questions about weight, about the medications, about dietary changes. Unless your head's been buried in the sand, shocker, there's tons of new drugs that are out. And I'm sure everyone knows someone who's used them, someone who's had a good experience, some have had bad. And we're here to answer everyone's questions about, what they mean, what they can do for patients, and the roles in women's lives. So we're going to go around and have everyone introduce themselves. Suzanne, do you want to introduce yourself first?
Yeah, I'm Dr. Susan Hall. I'm a senior partner with Eastside Gynecology in Metro Detroit area.
Hi, Dr. Stephen Lefkowitz, one of the OBGYNs at Somerset Gynecology in Metro Detroit as well.
Hi, I'm Dr. Lalanya Moore. I am one of the partners at Women First OBGYN in Southeast Michigan.
Hi, everyone. I'm Dr. Thomas Wolf, founding partner of Pink Creek OBGYN in Rochester, Michigan.
Awesome. Well, thank you guys so much for joining us. I'm sure all the women out there recognize these faces, that people who have delivered their babies and been their tried and true gynecologists throughout the years. We feel so honored at True Women's Health to be partnering with you guys so that we make sure that we're providing women the best care and answering all the questions that they have about weight loss and hormones. And we really hope that this is a fun conversation. We want to let all the women know out there that if you look in the comment section, feel free to ask questions and sort of anything's on the table, whether or not you want to talk about hormones or weight. And we are here to sort of answer those questions. So, I've been in, position for almost, I love it. Right away, someone's delivering babies. Someone gives a shout out to Dr. Wolf of delivering babies. I love it. Here they come. I think it's so awesome. Thank you so much, Sherry.
That's awesome.
So, I've graduated from medical school about over 20 years ago. And I think, 15 years ago. And I think that since that time, we just started sort of talking about obesity, but can you guys just reflect a little bit of how, women struggling with obesity has affected your practice over the past 10 years or so?
Yeah, I
think. Go ahead.
Sorry.
Go ahead.
Oh, okay.
Go ahead, Suzanne. Yeah.
Dr. Hall. And I think that one of the hardest patients to approach from, me being a generalist OBGYN is that woman who sort of just doesn't feel herself, with one of the main complaints being, her inability to lose weight. Primarily, I'm probably talking about that perimenopausal or menopausal woman who just feels that she's, doing exercise and watching diet and still just having a lot of problems with getting the weight off. So yeah. I think we do that every day.
Yeah. And it does feel, I know even coming from a doctor point of view and hearing patient stories, it just feels so frustrating to kind of keep giving the same advice sometimes of just like, watch what you're eating, go move more. And these women are like, I'm doing that. I'm busy with other life experiences. Like I just don't have as much more time to sort of dedicate to hours of exercise. So it can feel really frustrating, both on a doctor end and a patient end.
And I think the other side of the equation too, again, I am with Dr. Hall. A lot of us in perimenopause are struggling with these things. But then on the opposite end of the spectrum, I have patients who really want to get their weight down to prepare for pregnancy, to prepare for any stage of life. Trying to reduce risks as we age is extraordinarily important for our heart health, to prevent diabetes. There's so many other areas of concern that people have. But in our world of OBGYN, I think perimenopause, I think preparing for pregnancy, and people really just trying to do their best to be their best. And when we're not seeing those results, that's just frustrating.
I think I think the frustration of hearing the patients really struggling with the weight loss and then sort of ping-ponging, trying different diets, going to different places, and me appreciating like that's not a good comprehensive medically based program that they're kind of doing, and just kind of seeing that they're probably not going to meet their goals and objectives. And so I'm so glad that we've partnered, Celia, Dr. Egan, with you to have you guys available, because your program is really well thought out. It's exactly what I think patients, what I feel comfortable with, the trust that the patients have with me, that I feel comfortable having them to go to see you and working with you.
Yeah. And so just explain a little bit of what we do. So, we're offering your patients what we call the Together Weight Journey Plus. And the goal of that program is to provide an evidence-based, medically oriented program for women who want to lose weight. When we think of women who want to lose weight, we think of women who need to lose a lot of weight, maybe over 100 pounds, which we have those women in our programs too. Maybe they gain 10 to 15 pounds around that perimenopausal time, and they just need to figure out some, changes in their life that would make sense. When I have a woman who comes into my office and says, I need help with weight, I think of three separate buckets. The first bucket I think of is, okay, we have this extra weight on her body and what we call like fat mass. I need that to come down. I need that to be extra weight off of her organs and off of her joints. So that is a target of treatment. The second bucket that we talk about is the overlay of what we'll call metabolic disease, right? We know that when a woman gains extra weight, we tend to see fluctuations in higher blood sugars, higher inflammation, higher cholesterol levels. That does increase risk to all those things that no one wants, like cardiovascular disease and dementia. So we'll look at all those different, weight-related comorbidities and check those out and make treatment options based off of that. And then lastly, the third bucket that we treat is a woman's relationship with food. So a lot of the times, sometimes doctors will give weight loss advice, or they'll be talking about, let's eat healthier. But if a woman is really struggling with high cravings or high hunger, and that is just driving her nuts, it doesn't really matter how much coaching you do. You got to work on the back end of that relationship with food. So when we talk about what we're going to do in terms of treatment, and that may be medications, that may be dietary changes, that may be exercise recommendations, that may be some of these other mindfulness programs that we have to work on our relationship with food. We're thinking about all those three buckets and how we want to change a woman's medical plan to improve those three buckets. And Christine said perimenopause at 36, postmenopause at 50, 69, still struggling, right? And I think that it is totally true. Christine, I think you're one of the many that's out there that, is trying to figure out what to do with those hormones. And of course, weight sort of kind of tags right along with that. So in thinking about, the weight journey program, tell me, do you guys have women who say that they struggle with cravings? That's definitely a part of perimenopause as well.
All the time.
Yeah.
Yeah.
It's amazing how that mismatch of, estrogen, or as that estrogen level falls and swings with perimenopause, how all of a sudden, like that voice for chocolate and chocolate chip cookies and ice cream that's calling us, like, outweighs any logic that we have. And it sort of snowballs because obviously women who are struggling through perimenopause and menopause have night sweats. Now we're not sleeping. Now we know that that impacts our ability to make good food choices. So it sort of snowballs out of place. And that's definitely something that we love to address. It's honestly one of my favorite aspects of weight management is working on getting women's relationship with food sort of back in line and helping them recognize some of the patterns to their cravings. And I know that's a big part of being pregnant. Is that just like true that every woman with pregnancy has cravings, or would you say that that's picking and choosing different cases? You guys have definitely seen more of that than I have.
I'd probably say it's probably woman specific and kind of choosing. But, back to that perimenopausal woman who, is struggling with the hot flashes and night sweats and sleep disturbances and just not feeling well and not feeling her best the next day. I definitely think that affects her ability to pick the right choices for food and exercise.
Yeah.
So it all sort of goes hand in hand.
Yeah. So if you're in, another thing with perimenopause is women can just feel fatigued, right? And so again, if we're coaching women on just doing more and more exercise and they're already battling so much fatigue, again, it just sometimes isn't the right time to make that heavy recommendation. So we do try to sort all that out. Denise said she's 38 and headed into perimenopause, and she's struggled with food noise her whole life. Denise, I hear this all the time, and I know how loud that voice can be. And now she's saying it's even louder than it was before. And we definitely could talk in our program about different foods that maybe could change that, hormonal, shifts that we could talk about, and medications that would make that possibly better. Of course, part of the obesity medicine program is the use of anti-obesity medications. Some of these medications have been around a really long time and have been configured in different ways, paired up in different ways, and have been really safe. And then, of course, over the last 5 years or so, we've had the advancements of a whole new class of medications. We call it NUSH therapy, or nutrient stimulating hormonal therapy. The world knows it as Ozempic or GLP-1s or injectables. They go by a lot of different names. In our world, in the obesity medicine world, it's very exciting because for the first time, we've really been able to see a good deal of weight loss that's been maintained over 4 or 5 years and longer in some of these studies. These are very potent drugs, meaning they can go awry really fast. And so we hope that when a woman chooses to do that she's doing it in a way where she's working with a provider who knows exactly what they're doing, knows what to look for, knows when to sort of maybe hold back, and can find a good pace. And that's what we're hoping to offer to all the women of your practices.
I think that's amazing. And there's so many of our patients that may be even searching for the medications, not even with their primary care physician.
Yeah.
So they're off on their own. And as you mentioned about the potency of the medications and, the side effects and, just being able to have, a trusted professional that's, with them. So, I hear stories about people getting the meds, but then they can't reach the provider that was associated with it, with the cell. And so to have a sort of partnered program, to me, with True, I think is just a wonderful opportunity.
Yeah. And I think that, we never had designed this to be something where we just deliver blindly in mass medications to women. We always wanted it to be in partnership and in a safe, effective way, because we really believe that that's how this is going to be the most successful. When I hear stories of where these drugs go awry, a lot of the times people are just using way too much of what's there. It's funny, there isn't actually great research to suggest a rate of weight loss, right? We all know when weight is too high, what that means. And we can see definitely mortality risk with, higher as the BMI goes up and higher rates of cardiovascular disease and cancer. And we see all that connection. but we have really not that great of data of what happens when we lose weight. How fast should that number be? How slow
Interesting.
should it be? Right? We don't have any of that information. And even us at our last major conference, we're kind of all scratching our heads like, should a patient that's already lost, let's say a patient's already lost 50 pounds and maybe a normal BMI would be another 50, should they lose that weight? Should they hold? Like, what does that mean? And so all this is going to be teased out over the next couple of years. And you really need to find a partner who is staying on top of it and making sure that all these women are sort of staying safe. One of the big side effects is GI tract side effects. I don't know if you've had a lot of women call your office talking about that, or your staff has had to deal with troubleshooting through some of the nausea and GI side effects that people see.
I definitely
I
have
would say
been talking
no.
about it
No.
at their
Yeah.
annual exams for sure.
Yeah. And I think that it gets into just, again, finding that right dose for that patient, finding that sweet spot where they're still able to get in enough nutrition and they're still able to sort of maintain a good relationship with food. One of the things that we see is it can feel, just like Denise was saying, that food noise is so loud. It can feel so freeing for the first time in a long time not to have that constant food noise, but we still want some of it, right? We still want you to be able to enjoy life, live life. Food is such an important part of our culture, our travel, our family events. And so it really is finding that sweet spot with, being able to lose weight and getting healthy, but also, being, confident that you can move away from just not only relying on the medication. So Marianne says, so what is this all about, obtaining an injectable drug? So Marianne, what we do in our office in our program is obviously we'll have a big conversation about whether or not using an anti-obesity medication makes sense. If using that class of medication makes sense for you based off of many different things that we look at, how much weight you need to lose, whether or not you have any metabolic disarray, meaning your blood sugars or your cholesterol levels will be off. That's, a conversation that we'll have. We always try to run things through people's insurance. We know that over the last several months, that's become a lot more complicated. We have a whole team kind of dedicated to trying our best to make sure that those loopholes are closed to the best of our ability. And then, of course, we give you as much up-to-date information about the cash price and trying to keep it to the forefront as possible. It's frustrating that these drugs are not sort of broadly covered by insurance plans. That may change kind of at any moment. So we're really hoping that everyone's sort of in the loop about what's going on. At least they know all their options. A lot of, the price a couple, 18 months ago felt like it was in the thousands. That is not the case anymore. It's come down a lot to a couple hundred, which I totally understand still feels like a lot, but it's definitely not in the thousands that it was about 18 months ago. And Sherry had a question. She's just expressing that she's almost 50. Happy birthday. And she's been working on a bunch of different stuff, and she's not reached her weight loss goals despite doing all of the things that she's been coached on doing. And she's considering a medication, and she's concerned about insurance and costs. Sherry, we hear that. And like I said, you can always talk with one of our staff members before you signed up about what that would look like. And we're always happy to have that conversation with you to kind of give you a review of what that would look like if you needed guidance. Remember, there's actually older anti-obesity medicines too that are not those expensive injectable medications that can be really impactful for the right person. So we always bring all those medications to the forefront as an option as well, just to make sure every woman has all their options on the table. Of course, just like Sherry's done with a nutritional coach, if medications are not something that you want to do, that's okay too. We do a lot of nutritional coaching. We have a dietitian that works with us. We have meal plans every week. We also coach on what we call very low calorie diets, which are basically using medical grade meal replacements, which was sort of the mainstay of obesity medicine before the injectables became a lot more popular and can be really an important part of a program if someone doesn't want to use medication. So we really make sure that we're checking all those boxes. in terms of what we need to do to develop a good program for a woman. And I know a lot of people are commenting that it's been such a struggle to get these medications, which we totally understand and know. And Tanya asked a couple hundred, how often? Tanya, that's a really great question. I have a hard time answering that because a lot of the times that depends on how much you need. And I know that feels like a non-answer, but what we've found is not every woman needs the same dose. So I have some women that are on the highest dose and still don't lose weight. And we're waiting on that next drug to sort of drop in the late fall. And I have some women on the smallest dose, like once a month, and they're doing quite well. And then everyone in between. And so I have a hard time giving an idea of exactly how much you would need without kind of looking at your chart and kind of taking your history and moving forward. But usually it's an upfront cost of about $300 to $400 upfront for the first kind of section of medications at least. So I don't know if that was helpful if that's helpful in answering your question. And we do work with patients who are diabetic. So particularly, type 2 diabetes kind of runs hand in hand with obesity and obstructive sleep apnea. So yes, that's definitely something that we work on. And a lot of times having type 2 diabetes, although that is not a great diagnosis to have, sometimes we can squeak through some of these medications with that diagnostic code. So again, we try our best to kind of work through some of those insurance loopholes. You guys, being in the internal medicine world is definitely different than the gynecology world. But we know that we deal with so many of the same problems like type 2 diabetes and hyperlipidemia, which is high cholesterol levels and that extra weight. Have you guys, seen this be really impactful in your sort of day to day? Like, I'm sure you guys talk a lot about this with your patients at your annual visits.
I wish we had more training. As OBGYNs don't necessarily get great training on all these factors. And I think, I guess I'm asking, maybe you can speak to sort of your assessment of the patient before you even get to what medication or what treatment. I do understand that the program does, a comprehensive, evaluation of hormones and metabolic status to sort of tease out what facets, you're looking to.
Yeah.
So could you speak to that sort of evaluation of the patient?
Yeah. So when we get started, we have patients complete an intake form, which talks a lot about trying to understand where they're at and what we'll say their phase of ovarian function. So to understand where their hormones are at, to understand what the relationship is food is like. Maybe they're struggling a lot with high cravings and high hunger. Obviously we're going to collect their past medical history. We do ask that they get some basic labs if they haven't gotten those recently, looking for things like high cholesterol, type 2 diabetes, insulin resistance, and being able to, when we have that first appointment, kind of give them a fair snapshot of where they're at in terms of their metabolic health. Every visit is an hour to get started. And a lot of that is, a huge section of that is goal setting. Because what we really want to do is make sure that we're on the same page as our patients. Because we may, as doctors, we sometimes have goals in our heads of what makes the most sense in terms of what would make a woman healthy. But some women have different goals in mind, and we love to make sure that we're all on the same page. Any follow-up is 30 minutes. And we are always a phone call away. So we are 24/7 in case you have questions or side effects or just need to run through again what we talked about. All those things are available to anyone who is part of our program. And we have team members sort of watching our patient messaging, both mostly 24 hours a day. So I know that it can be really hard for a lot of these online programs because most patients tend to just get into a loop with some of the providers. And so we really are passionate about making sure women have, providers available to answer all their questions that are there. Because we know dealing with some of these side effects can be so frustrating.
Mhm.
As we work through the program, we'll do some other goal setting, around metabolic health, checking out whether or not they have diabetes, thinking about their cardiovascular health, talking about exercise goals. And we really try to address any barriers that are there and work with the woman to sort of bring all those down to the best of our ability. They'll have access to all of our content pages where we have recipes and meal guides and guides to using medications and guides to exercise and a review of where you're at in terms of perimenopause and what that means, and all those different aspects of kind of where a woman is at in midlife. So our team just put up some links if you're interested in terms of how you can learn more about the programs through your gynecology offices, and making sure that you guys can get all your questions answered before you sign up. Do you guys have any questions about the program? I know we've talked, you guys have heard my partner and I, Dr. Bitner, talk a lot about kind of what we do. What kind of pressing questions do you guys have from, as the doctors of these women?
Well, I've asked a few of them, about the, workup and assessment, which really lends to the partnership, that I think the program has with the patient. And I think, that's what's missing in some of these other programs. And it's also what I can't literally provide for them, just
Yeah.
in the element of being, you know, a specialist. We are specialists in obstetrics and gynecology, and have time constraints in dealing with that element. So to be able to, within our own practices, offer, a program that is trusted and, evidence based, which is one of the things that I feel like is so impressive and important about the program, is it's based evidence-based practice, and then to have the the support in all of the avenues that you spoke about. I think it's a wonderful thing for us to be able to offer.
Dr. Hall, thank you so much. Yeah, I think safety and effectiveness are two of the main things that really drive us in our program. And I'll maybe say something of what the program is not. So we don't want to order any vitamin studies or any hormone labs that we don't think are going to impact care. So sometimes you can find programs where they're drawing like thousands of dollars of labs. That's really not our goal. And we try to match up any labs that we draw with something that, we're not going to repeat a lab that you just got done recently. So, we really are trying to draw labs, and, anything that we recommend would be off of a recommendation that we truly believe would be helpful. Mary Ann asked a question. When you prescribe Ozempic type of medication, what is the criteria you get to use the insurance to pay for it? Marianne, I think that that's a great question. Unfortunately, I can't answer it because the insurance companies all have different rules, and it really depends on your insurance plan. I've seen everywhere from insurers need someone's BMI to be above 40 to their BMI needs to be 27 with one weight-related comorbidity, such as high cholesterol, and everywhere in between. Some programs need to have you failed some other nutritional plan or an exercise plan or other anti-obesity medications such as Contrave or Qsymia, phentermine, some of the other ones that are available. So it's really a hard question to answer. We're totally on top of, digging into your insurance plan to figure out exactly what that criteria is. And then we'll work with you as the year goes by, right? Because different insurance plans change kind of on month, year by year basis. So we will try our best, if it's something that we can get covered for you, to make sure that that can actually happen. But I know it's definitely a point of frustration for doctors and patients to see if we can get these medications covered. I think one of the more exciting things, just to update you guys, there's like two or three more drugs coming out in the next 6 months. So one of the drugs that's coming out is what we'll call a triple agonist. So this will be now the third generation of drugs that's out. Technically, I guess we would call it the fourth generation. So semaglutide, that makes up Wegovy or Ozempic, was one GI tract receptor agonist, or it basically mimics one GI tract hormone. Tirzepatide, which makes up Mounjaro or Zepbound, is a dual agonist. So basically it's mimicking two GI tract hormones. Coming out in fall 2025 will be a triple agonist. So now we're getting sort of mimicking three of the GI tract hormones, which we believe will be even more impactful in terms of having patients lose more weight and having better blood sugar control. A lot of these questions are going to be, well, who should have a triple agonist? Who should have a double agonist? This will be a very interesting space to figure out. We're sort of leaning in the direction of those who obviously have much more what we'll call metabolic disarray, meaning they need to lose more weight, they need more help with their blood sugars, would make sense of being a primary candidate for the triple agonist. But this is what we're here to help you guys figure out, right? Is sorting all these different pieces out. And this is only going to get more complicated. Another exciting part of the anti-obesity world is in the beginning of 2026, they've taken all these drugs that are currently now shots, and they've gotten it cleared to put in a pill form. So I have a ton of patients who are like, no thanks to taking a shot, because needles, it feels just really powerful to have to inject a shot. And now we'll be using pills. They're not quite the same weight loss results as some of the shots, but what a great option for women. And we really hope that now they're in pill form, they can be made in sort of mass quantities and much more available. This space is really just sort of evolving and changing. And it's, it's a very exciting time to be a doctor, because you get to try all these new things out and try to get women on the right paths as quickly as possible. But two, it's just, for the first time, we're really having good solutions for women who are struggling with weight. And that's exciting.
I have a question.
Yeah.
Don't mind. Okay, so I've seen some things about the GLP-1s reducing cravings for alcohol and other benefits. I mean, again, it's not in my purview of care, but could you speak a little bit about other benefits?
Yes, that's a great question. So it's so interesting, because our brain, that like back part of our brain that's sort of trying to run the show, meaning it's like making sure that we're hydrated, making sure we're safe, making sure our immune system's working. That back part of our brain's trying to figure out what's happening with the food coming in. How much energy do I need to take in? How much energy am I expending? Your brain's trying to figure that out. And part of that whole energy balance is our fat cells. And so it's not that hard to believe that our GI tract, which is watching the food coming in, our fat cells, which are the storage unit, and our brain, which is sort of the woman in control behind the scenes, are all working together. But our brain is not as elegant to say, I want food versus I want something sweet versus I want a drink. It just is sort of like, it just has the I wants, right? And it just wants something, and it's being driven like sort of on these reward center pathways. What we found is if you're able to satisfy basically the food noise, a lot of the time, the noise for some of those other groups, alcohol, sweets, sometimes even like gambling and some of the other things that people struggle with addiction models with, tend to come down. Now, there was one study looking at semaglutide, which is Ozempic, saw a decreased rate of alcohol, basically cravings. That was one study, and it was really surprising to sort of finally seeing written paper. However, I'll say in my practice, I see it all the time. Women are just like, I am just not interested anymore. And it's a hard thing to say that that's bad, because we're learning more and more that any amount of alcohol is not a good idea. And so, these women who were like, I've been maybe having 1 or 2 glasses of wine at night. Now we're just like, I'm just not interested. And it's really been a very interesting, helpful kind of side effect to using these drugs. By no means do we would say, oh, you're struggling with alcohol, we're gonna only prescribe you one of these drugs, because there's many other plans, to treat alcohol use disorder. But I do think that it's really interesting and really impactful to, sort of bring down any alcohol, particularly on a daily use, down to as little as possible. I know it's hard. I mean, I know all of us doctors out there ask about, how much alcohol women are drinking, and we're all working on trying to find that balance with, getting patients as healthy as possible on many different aspects. And so I'm just so grateful that it definitely has not made it worse, which is, one of those things that we always think about when we're trying to make shifts and changes to our food noise and our craving and some of those food recommendations. So that's exciting. I know that that's something, when people talk about pulling back on alcohol use, a lot of the times they'll replace those cravings with sugar. And that's when we talk about mindfulness models, craving models, that's a lot of what we dig into, is trying to find those different ways that we're relying on some of those reward center pathways too often, and trying to break that open so that, if a woman does want to come off some of these medications, that we have a good plan in place sort of to lean on, instead of just pulling these medications off without having any sort of plan or training. Denise is asking, as a member of this program, can you elaborate on the behavioral supports that were implemented that may help those of us who struggle with consistency? The initial buy-in to healthy living is easy, and I'm hoping this helps the yo-yo addressing. Denise, great question. So, we do a lot with mindful eating, intuitive eating. There's a lot of different names for it. We're trying to figure out a way for, every woman to reflect a bit on, how they're leaning on food as part of their reward center, and, as part of stress management, and figuring out all the different ways that we can both recognize that and change. It's totally crazy how even different foods we eat can change that food noise and those craving levels. We, of course, want to work on getting our hormones sort of as stable and up to snuff as we possibly can. So we work on all that different stuff together to sort of change that yo-yo mentality. We kind of break up even our food recommendations into, are you someone who needs just education? Or do you have no idea what healthy eating is? Do you need help with logistics? You know what to eat, but how am I I'm at a baseball game. How am I going to make this happen here? Right. And logistics, or is it just ability? And we try to work on all those different arenas at the same time to prevent some of that yo-yoing that can happen with different dietary changes. A lot of it is sort of being self-forgiving and finding that balance that comes with, living life. I think we've found more and more that the all in and out tends not to be as helpful. I'm not going to eat any sugar or any carbs or any meat or any, kind of locking out these big food groups tends not to last as long. And so we're trying to find that balance for the individual woman and where we can sort of meet her goals. Christine says, I've been told that I do not eat enough. That is why I'm gaining weight. Is that possible? Christine, it is possible. Your body is communicating between your liver, your muscles, your stress organs, your brain, and they're all trying to figure out what's going on in terms of the energy coming in and the energy coming out. Unfortunately, if you're in a position where maybe your hormones aren't right, maybe you're a little too stressed, and then you're not eating, your brain basically is in a panic state. And it's we better store as much as possible. It can be really tricky and confusing because you're how is that possible? It goes against everything I've ever been taught. And I always tell women, losing weight's a little bit more about chemistry than physics. It really is just trying to get that right balance of those hormones where our body feels comfortable letting go of that extra weight. And sometimes not eating enough can sort of induce sort of at least a weight holding state versus just a weight losing state. Great question. Yvonne asks, how does hormone therapy affect potential weight loss? Would this be possible option choice versus starting an obesity drug? What are some of the deciding factors before using the obesity medicine drugs? So yes, sometimes for women, Yvonne, maybe making changes to their hormonal therapy would be our first choice. And we do not always just jump to an anti-obesity medication. We decide on using anti-obesity medications on a variety of different ways. Sometimes we'll use it to treat cravings. And if someone's really struggling staying on a good food plan, maybe despite having their hormones and other lifestyle factors optimized, then we'll make a decision to add on an anti-obesity medication. Maybe they're a woman who's really struggling with high blood sugars and insulin resistance. That may be another reason why we'd make a stronger recommendation to start some of these medications, because we know it can be really hard to lower that insulin level without the use of of medications. Not impossible, just makes it a little bit harder. But that's definitely always a doctor-patient conversation that we would have. Denise says, thanks, you are welcome. We are always happy to answer questions. This is like one of our favorite parts of working with women in these programs, is educating women and having them feel confident about what's going on in their bodies and what they're going to do next, right? There's nothing more terrifying than just having no idea what's happening. So other questions, doctors out there, about our program that we can answer?
I wondered if you could touch just a little bit about, Yvonne had this question about how the hormones are relating. And I know this is mostly focused on the weight journey, but you also are working with Dr. Bitner on the hormone side of things. I wondered if you could just maybe mention your relationship and how that works together, because I think a lot of these women in the chat are in this stage of life where we're in that perimenopause, menopause.
Yeah, absolutely. So if you're someone who's like, I need more help than just helping losing weight, and I really, not only do I want help losing weight, I also want help understanding where I'm at in terms of my phasal ovarian function and my tools to be used during perimenopause and menopause. We actually have a second program called the Together Wellness Plus program, where we dive deep into symptoms of menopause, treatment options of menopause, and all the weight loss stuff, and other cancer screening to make sure every woman in midlife knows where they're at in terms of their cancer risk, bone health, sexual health, a lot of different topics that come up in a primary care's office that sometimes women don't get the best answers for. That is $250 a month, which is a little bit different than our weight program at $100, but it can be checked out at the same places as the rest of the Weight Journey Plus. And, the Wellness Plus program, I would say, again, dives pretty deep into treatment options for menopause, and also goes into some of those other areas that women have so many questions about. So anyone else have any other questions about the Weight Journey or the Wellness Plus journey before we move on to some of our tips our take-home tips for the evening? All right. So at True Women's Health, we always sort of close down these conversations with tips for women to sort of think about. And before we do that, Tanya just says she is working with an endocrinologist who knows a lot about type 1 diabetes. We would have a conversation, and we want to work closely with your endocrinologist if we were going to make any changes. And perimenopause is definitely impactful on working with blood sugars. And you definitely could call our office and we could see if that would be a good fit. Thanks, Tanya, for asking that question. Okay, so we are going to move on to our 5 take-home tips. Tip number 1, what is your picture of self? One of the baseline things that we talk about in our Weight Journey Plus is where you as a woman want to be. What does success look like in terms of losing weight? Maybe it's a number, maybe it's feeling confident in your body again. Maybe it's a certain activity that you want to do that you've not been able to do in a bit of time. There is no wrong answer, and we want to make sure every woman understands sort of where they want to be so we can make sure that we get them there. Number 2, what is your relationship with food? This is so important to think about. honestly for everyone, because it's shocking, honestly, how much we sort of rely on food for stress management, for happiness, out of boredom. Before I started doing this work, I kind of was like, I don't have a problem. And then the more I got involved with it, I was like, oh my gosh, like, holy smokes, I am eating all the time, like post call. And every time that I'm stressed, I'm popping candy in my mouth. Like, wow, it's something, unless you paid a little bit of attention, it's shocking how much, we sort of add food in. And that's okay if, you need food for, joyous events. Again, it's an important part of life, but we just want everyone to know and reflect on what the relationship with food is like, and to see if we need to pull in any other tools to improve that. Maybe that's a mindfulness class, maybe that's medications, maybe it's just working with a dietitian to find a balance in some of that intake of our food from a day-to-day basis. But, reflecting on what your relationship with food on is crucial. Number 3, consider an anti-obesity medication. There are a lot of different classes out there. So we're always here to be educating our patients on not just the injectable class or the GLP-1 class, but some of the older drugs that have been around for a long time. We definitely still see success. In fact, today I actually saw a woman who's lost over 20% of her body weight on just the older class of medications, and it's been so impactful for her. So we do not just write those off as they don't work anymore. They're all about finding sort of the right, woman in the right case for those medications, and they still continue to be a great option to use. Number 4, are these medications safe for me? Remember that particularly these newer class of medications are really potent, and we want to make sure that anyone using them is staying safe first and foremost. And so we just want to make sure when we write these medications that we review everyone's past medical history, because there are some contraindications to using medicines in all the different classes. And we want to make sure that we're all on the same page about goals and nutrition. So again, if you're choosing to use these medications, we want to make sure you're working with an experienced provider that understands sort of all the side effects and contraindications before you start using any of these medications, short-term or long-term. All right, number 5, what is the right weight for me? I actually answer this question probably 3 or 4 times a day. And it's hard because, like, as I've said before, there's not a lot of great science that's pointing us in one direction. And this will be really exciting and interesting to see some of this play out. I always tell women it comes back to sort of where that woman wants to be and what her goals are and what is her picture of self in terms of, figuring out what would make her feel the most confident in her day-to-day life. So there is not one answer. We talk a lot about losing 10% of your body weight. So if that's a woman who's 200 pounds, it's like losing 20 pounds or so, which for some women does not feel like a lot and not quite where they want to be. But even that we would consider to be success in the obesity medicine world. So there is not one right weight for every woman. And we always work on finding out what a woman's goals are and where she wants to be. So those are our 5 take-home tips. And then we have 5 questions just to ask if you were asking your doctors about the Weight Journey program. So our 5 questions that we can ask: could hormones or insulin resistance be affecting my weight? So remember, our body is really this beautiful calculated machine. It's watching sort of what's happening on the outside, meaning the food coming in, how much energy it needs going out, and what's going on internally. And, it's funny, when our hormones change with insulin, it is sort of that miscue that things are completely off. And we know that lack of estrogen or those huge shifts of estrogen that can come with perimenopause and menopause definitely can affect your weight, even without changing the amount of calories you have coming in or your exercise plan. So that's always worth a conversation to have with any of your doctors. Number 2, am I a candidate for anti-obesity medications, and where do we start? So again, the standard recommendation is anyone who has a BMI above 30 or a BMI above 27 with a weight-related comorbidity. So maybe that's type 2 diabetes, prediabetes, high cholesterol, obstructive sleep apnea. There's a lot of things on that list that would be, you would fall within the clear criteria to start on an anti-obesity medication. Sometimes we'll treat high cravings as well if you don't necessarily fit into any one of those boxes. And it all starts with collecting information and collecting some basic labs and learning where that patient wants to go. All right, number 3. How can I measure progress beyond a scale? So a lot of women will talk to us about, their physical activity goals. Maybe they want to get back to running, or they want to be able to play a game with their grandkids. And that can be a great measurement of, progress and how they feel successful. A lot of women will talk to me about their clothes. They'll say they want to get back into a certain wardrobe, or they have beautiful clothes of a different size that they're trying to get back into. So that's another common way that women will talk about measuring success. Sometimes it's just getting all those risk factors as healthy as possible, meaning getting their hemoglobin A1Cs down, which is a tracker of diabetes, getting their cholesterol levels down the best that we can. So it depends on, everyone's a little bit different, but those are all different ways that we can sort of measure progress and success. All right, number 4, how else can you support us outside of using medications? So again, we've talked a lot about mindful eating and your relationship with food, and we love to support that journey for a woman. Everyone can probably learn a little bit more about nutrition and the right foods that support your body. We all can use tips about how to actually make that happen in the real world with busy lives and busy jobs and busy kids and busy parents and all the different things that are out there. So we work on that. We do help guide some in some exercise, and we offer different, information from trainers and different things to kind of get you started in terms of the exercise world. So all those different areas can be impactful. And of course, the overlying theme to all this is we want to make sure your hormones are in the right spot as well. So there's so many different places that we can talk about to try to get you on track if medicines is not on your plan. And number 5. Last one. Or maybe that was it. I think that was it. Sorry. We only have 4 today. And Tanya asked, why isn't type 1 diabetes on the list of weight-related comorbidities? I think that this is a great question. So very interestingly, type 1 diabetes is where your body doesn't make enough insulin, or mostly none at all, leading to high sugars. That is less oriented with with a weight loss journey, or with gaining weight or having obesity, than type 2. Type 2 diabetes also has high blood sugar, but those patients tend to have insulin, but the insulin is just not working at the cells the right way, and it's not allowing the sugar to move from the blood into the cell itself. And so that's why that difference between the 2 different types of diabetes is why type 1 is not on the list, because it's not driven by the inflammatory energy mismatch that comes with obesity. And it's honestly a completely separate disease process. So unfortunately, that's why it's not on the list. However, there is more conversation to be had about the use of any of these medications with someone who has type 1 diabetes. And that's always sort of a good conversation to have with any provider. That was all the information that we had. Thank you so much for talking with me tonight. I know that you guys have precious time, that when you're not being so busy delivering babies and working so hard for your women of your practices, I want to thank you again just for talking with us and making sure that all these women feel educated if this feels like the right choice for them.
Yes, thank you so much. And, providing like this patient-centered program to me is so important. And your commitment to the total woman is evident. And I think we're all honored to be able to share this with our patients.
Yes, well, we are so excited to partner with you guys and make sure that we're all keeping these women headed in the right direction and safe as possible.
Thank you. Love the program. Thanks.
Yes.
Yeah, thank
All
you
right,
so
guys.
much.
Thank you.
Yes, thanks so much. And we look forward to keep talking about women in the future. Thanks.